Shall we start? Hello?
Yes, sir. We can start now. Yeah.
So, good evening, everybody. Localization in nervous system is a very broad topic. So, though I wrote cortex, brainstem, spinal cord, peripheral neurology, we'll do from spinal cord and downwards today, and we may take another class for the cortex and brainstem. Are you able to hear, all of you?
Yes, sir.
Yeah. Okay. The spinal cord connects the brain with the peripheral nervous system, and it is segmental and it has got vertebral levels. It is largely inside the uh, vertebral canal, as you can see here, and it conducts various messages from brain to the spinal cord to the peripheral nervous system. So it has got ascending tracts and descending tracts. The spinal cord is segmental. It divides into segments. The segments and vertebral levels are sometimes not, they are not at the same level because of embryonic development. The spinal cord is pulled up. So spinal nerves 1 to 7 emerge above the corresponding vertebral body. The remaining nerves emerge below the vertebral body. So today we'll be talking about spinal cord and cervical and lumbar roots and peripheral nerves. Just concentrate on this. So the spinal cord ends at the L1 vertebral body, and below that you can see the L1 vertebral body here, and below that you have a arachnoid sac which contains the cauda equina, or the terminal part of the spinal cord. And it also has sympathetic and parasympathetic fibers running into it, which supply heart and baroreceptors and arteries of the thorax and lower thorax. And so it carries a very important function. It has got descending tracts like the corticospinal tract, tectospinal tract, rubrospinal, and reticulospinal, vestibulospinal. All these tracts are motor tracts which are conveying the action potentials to the ventral horn, and thereupon it goes to the nerve and muscle. It also carries the sensations from the periphery, the superficial sensations like temperature, pain, pinprick, and all these sensations are carried upwards in spinothalamic tract. The proprioceptive sensations like uh, vibration, joint position sense, 2-point discrimination, they are carried in the posterior columns. Apart from that, there is that is dorsospinal cerebellar tract, and the spinal cerebellar tract that also carries to the equilibrium proprioception. So there are tracts which are ascending, there are tracts which are descending, which you are going to learn. And each spinal segment has got a dermatome, a myotome, and a vasotome to the corresponding body regions. So that's a basic understanding which we should have. And let us look at the vertebral column. Uh, sorry, yeah. Dimensions. The bony vertebral column protects the spinal cord that you have seen. And what is the length? It is about 45 centimeters of spinal cord. At birth, it is at the lower border of the L3 vertebral body. And in adults, its tip is at L1, L2 vertebral disc level, or T12, the lower border of the L2. The diameter of the spinal cord, you see what you see in diagrams looks very big, but it is only 13 millimeters in cervical and lumbar regions, and that is half inch. And in thoracic, it is 1/4 inch. This much narrow diameter spinal cord has to convey so many millions of action potentials from the brain to the muscles and from the periphery to the brain. The cervical anteroposterior and transverse diameters of the vertebral canal are also very important to remember. C2 it is 12.4 millimeters maximum, C4 it is 14 and C7 it is 11. And lumbosacral region, lumbar canal is up to 27 millimeters. And we call lumbar stenosis if it is less than 12 or 10 to 12 millimeters. So these are the important diameters of spinal cord. So we are getting sensitized to what is spinal cord, where it is lodged, and what is the vertebral body looks like, and what is the vertebral canal. So if you look at that, there are about spinal nerves are 31. The cervical nerves are 8, thoracic are 12, lumbar are 5, sacral 5, coccygeal 1. So all these nerves are originating from the spinal cord through the ventral root. They have to come out. The exit of the narrow roots, the C1 between the skull and the atlas, it emerges. C2 to C7, they above the numbered vertebrae, they exit. Like C7 root emerges above the C7. C2 emerges above C2. And C8 above T1 vertebrae. The remaining spinal nerves will exit below the vertebrae of the corresponding number. So spinal cord has got a ventral horn, a dorsal horn. For each segment, the motor nerves are exiting. The sensory inputs are coming into the spinal cord at the same level through the dorsal route. We'll show you that. So this is a vertebral body which has got a pedicle, superior articular process, the spinous process, the transverse process, and the inferior vertebral notch. And you can see one above these vertebral columns, vertebral bodies. In between there is a disc. This is the intervertebral foramina, and you can see the inferior articular process and this superior articular process, and it forms the zygoepiphyseal or facet joint. This is called the facet joint. So this is what you are seeing is from the lateral aspect. So from you look the anterior aspect, you have a canal here. This is the posteriorly, the spine is present, the spinous process, and it can be mobile, and there may be obstruction at facet joints, and there is a protection, and this is the vertebral body, and this is the vertebral canal. So just remember this anatomy, which is very important. The canal diameters we have already seen, and you can see now the spinal cord is visible here. This is the 1/2 inch or 1/4 inch spinal cord, which is lodged in the bony vertebral canal, and this is one spinal segment, and the spinal cord is surrounded by pyometer, arachnoid, and durameter, and this is the epidural space. So this is a pyometer, this is a arachnoid, this is a dura, and there is a sleeve of subarachnoid space all around the roots. This is the ventral root, and this is the dorsal root. This is dorsal root ganglion. You can see how it is exiting through the intervertebral foramina. This is the spinal nerve that is exiting through the intervertebral foramina and divides into anterior primary ramus and posterior primary ramus. So this is in essence, the vertebral body, vertebral canal, and also the spinal cord in axial section. You can see this, and you can see the spiral ganglion. This is the dorsal root ganglion. The facet joint on the axial section is seen like this. This is the vertebral artery in the cervical region. You can see the spinal nerve, which is divided into anterior primary rami and posterior primary rami. And this is the nucleus pulposus, annulus fibrosus of the disc. You've been hearing the disc prolapse, which is a common problem which gives rise to pain in the, when our disc prolapse is there, and the problem in old age, we develop bony outgrowths called osteophytes on either side of the, and that also will cause lot of pain on this abnormal growth of osteophytes. And you can see the facet atrophy. The facets are hypertrophied, uncovertebral joint hypertrophy. This is the disc herniation that can cause pressure on the root. And you see, spinal cord is covered by ligaments. This is a posterior longitudinal ligament, and this is a ligamentum flavum. So you should remember this anatomy because very important anatomy for spinal cord. And if you see the sagittal plane, how can the disc, you see the disc L5 S1 disc is pressing on the nerve and the S1 is coming out, exiting here, but it is L5 S1 because the S1 will be below S1. No, it exits below S1. So you see how the disc is pressing on the exiting nerve root. And there's a fiber tectography in the cervical region. You can see C3, C4, C5, C6, C7, C8, how they're exiting from the spinal cord. And these are the tracts that are coming from above, from the brain, corticospinal tract, tectospinal, rubrospinal, vestibulospinal, reticulospinal. All these tracts are coming down. And the spinothalamic tract and spinocerebellar tracts and posterior columns are ascending tracts. So you can see the cadaver spinal cord, this is spinal cord, and these are vertebral bodies, and these are vertebral spines on the backside. And there is a lumbar enlargement, and which we said up to 27 millimeters. This is normal. If it is less than 10 here, the diameter then called lumbar canal stenosis. The terminal part of the spinal cord is called the conus medullaris. Below that is cauda equina. All these nerve roots like the tail of a horse is cauda equina, and these other internal organs are seen on the sagittal plane, and this is the lumbar spinal cord which you have seen. Okay, so and if you look at the coronal plane, you can see the L4 vertebrae and the L4 spinal nerve coming out. L5 vertebrae, L5 spinal cord coming out. Similarly, S1, S2, S3, S4, S5 coccygeal nerves, they are all coming, exiting from the spinal cord and going to the periphery to the supply skin and muscles. Right. And you see, I said now terminal part of the spinal cord is at L1 level, they're called conus medullaris, and subsequently all the nerve roots are called cauda equina, which will exit from the intervertebral foramina S L5 below L5, S1 below S1, and you can see the pedicle of the ventral and deep by sensory nerves. Like in the lower limb, you have posterior tibial nerve, the common peroneal nerve, and the joint was the sciatic nerve and femoral nerve, optic nerve. All these nerves are carrying sensory information, and that sensory information enters the spinal cord, crosses the superficial sensations, cross side, and ascend to the brain through the spinothalamic tract. Similarly, the proprioception, this is the dorsal root ganglion, and the central process enters, and it doesn't cross, it ascends up. It ascends up on the same side. So position and vibration sense are called deep senses. They ascend up on the ipsilateral side, and from the pain and temperature cross to the other side and ascend up in the spinothalamic tract. So these are the dorsal columns, and that is spinothalamic tract. So you can see the motor fibers are coming down to supply various muscles. The sensations travel up and the motor fibers coming down. You can see the various muscle groups, the flexors of the hand and foot, extensors of the hand and foot, flexors of forearm and leg, extensors of forearm leg. All these are supplied by the anterior horn cells which are in the ventral root. So you can see now a brief the discussion of the spinal cord. This is a central canal. This is the central gray matter, what you are seeing here. And you can see the spinothalamic tracts, the corticospinal tracts, and the posterior columns. If you remember all these three, that will be wonderful. You can piece all these small pieces of information and join them later. And you can see please concentrate on what I'm telling. Don't disturb me by sharing. And it is there on the YouTube. You can see that, right? Crossed at this level, partly crossed at this level. So these are the tracts which are going up, and these are the posterior columns and posterior spinocerebellar tract and rubrospinal tract. And these are the motor tracts and sensory tracts, partially crossed or uncrossed, which we see. So now you see this is the ventral horn. The lower motor fiber is coming out and it goes and supplies the muscle where neuromuscular junction is there. So the upper motor neuron fibers are coming from the cerebral cortex. So lower motor neuron is from the anterior horn cell to the muscle, neuromuscular junction. Okay, now just have a brief overlook of all the tracts and their laminations, because tracts are formed and they're going to the brain. So initially they start with the sacral fibers, and subsequent lumbar fibers are added, thoracic fibers are added, cervical fibers are added, and all these fibers are slowly added. So CTLS, that's how it is called, CTL. Now you can see the efferent tracts or motor descending tracts are in the red. Then what you are seeing is the pyramidal tracts, and the extrapyramidal tracts are also seen: rubrospinal, reticulospinal, olivospinal, vestibulospinal, all these tracts. The sensory ascending pathways are in blue. They are narrated blue. They are also CTLS, spinothalamic tract, cervical, thoracic, lumbar, sacral. All these are ascending. This lamination is in the cervical region. This transverse section which you are seeing is at the cervical region. So, and all these tracts are travel up, and they synapse, the posterior column synapse in gracilis, fasciculus, and cuneus. So neurological examination, below the lesion of the any spinal cord or any damage, you will have weakness. That is because of motor function disturbance. You'll have numbness because of sensory disturbance. Because of disinhibition, spasticity will set in. You'll have hyperreflexia. And also there will be autonomic dysfunction in the form of urinary incontinence, constipation, and sexual dysfunction. So all these things are happening below the level of the lesion. So radicular signs and symptoms at the level of the lesion. That is, what is radical is nothing but the root that is coming out, the ventral root and the dorsal root, they join to form the spinal cord, and the spinal nerve. The spinal nerve divides into the anterior primary ramus and posterior primary ramus. So these are the roots. And if there is an irritation of the root, you get radicular pain. The pain will be distributed in the dermatomes. So you're going to learn about what are the dermatomes. The radicular pain is characteristically, it is felt in the dermatome, and you should know what are the dermatomes. If you put your hand on the back of the head, that is C2 dermatome, and if you put on the back of the neck, it is C3 dermatome. On the applet or on the shoulder, above the shoulder, on the clavicle, it is C4. Lateral part of the hand is C5. Lateral part of the forearm and the thumb is C6. The palm and the middle fingers, 2, 3, 4 or C7, and C8 is a little finger. So that's how the dermatomal distribution is there. And whenever there is a problem in the spinal cord, there is a level below which all the sensations are diminished. And there will be upper motor neuron signs below the lesion. That means increased stiffness, that is called spasticity, weakness, hyperreflexia, but there will be no wasting. There may be, because of autonomic nervous system disturbances, bladder and bowel dysfunction. So spinal cord level localized lesion, you should know this level. See, these are the dermatomal levels. If the at this C5 level, you'll have C5 myotomal affliction, C6, C7, C8 are dermatomal, and you can see patient complains of tight belt sensation at the level of the lesion, sensation below the lesion level are diminished. Sometimes, if there is a problem of syringomyelia, you may have hung level sensations, a few dermatomes below the lesion, right? So in the lower limbs, there is L1, L2, L3, L4, L5, S1 dermatomes. You have to know these dermatomes by heart. And so to revise the cross-sectional anatomy of the spinal cord, the vibration, joint position sense, two-point discrimination, deep touch are carried in the posterior aspect, the posterior columns. The corticospinal tracts, they are coming down from the cerebral cortex to supply the muscles. And if there is a disturbance or affliction or damage to this, there will be paralysis or paresis, spasticity, hyperreflexia, clonus, and Babinski sign. These are all the UMN features. The spinothalamic tract is carrying sensations from below upwards, and it carries pain and thermal sense. The spinal motor neurons, these are lower motor neurons. They cause their damage also will give rise to paralysis and paresis. But here you get hypotonia, areflexia, fibrillations or fasciculations, and wasting of the muscles. So these are the LMN features. These are the UMN features. Because there are autonomic nervous system feature also. There may be meiosis, ptosis, anhidrosis, enophthalmos. This is called, if it is in the cervical region, Horner syndrome, there may be urinary incontinence, bowel incontinence. So both dorsal columns, there will be vibration, position sense, two-point discrimination, deep touch disturbances. So these are all the features that can be felt by the patient. So ipsilateral signs. Now we look at the Brown-Sequard syndrome. If there is a problem on the hemicard is affected because of the brain and tumor or because of some other pathology which is pressing, what happens? Upper motor neuron signs are on the same side of the lesion, and there will be loss of kinesthesia, discriminative touch. That means posterior column signs are also lost. I mean, joint position sense, vibration are lost, and there may be autonomic signs. At the level of the lesion, you will have lower motor neuron signs at the segment. C5 means you'll have wasting of deltoid. C8T1, you'll have wasting of first dorsal interossei and all the small muscles of the hands. And because the temperature and pain are crossed, you'll have contralateral signs of loss of pain and temperature. So pain and temperature loss will be segmental at the level of the lesion. So just remember that Brown-Sequard is ipsilaterally you have motor weakness, ipsilaterally you have posterior column signs, contralaterally you have loss of pain and temperature. So this is true in the spinal cord, most commonly in the cervical region. Sometimes there may not be any pathology, but you have metabolic causes, nutritional causes like subacute combined degeneration, which is B12 deficiency. The corticospinal tracts and posterior columns are affected in this. And see, this is the posterior columns, these are corticospinal tracts. So you have a subacute combined degeneration. And suppose if you have a thrombus in the anterior spinal artery, the anterior part of the spinal cord is affected and the posterior columns are preserved. So spinal cord syndromes, and the terminal part, you have conus medullaris syndrome, where if the L1 vertebral level, the terminal part of spinal cord is involved in the disease process, it will cause perennial sensory loss, bladder and bowel retention, and minimal lower extremity weakness. There will be not much of weakness. But if the Cauda equina, that is the roots which are below L1, below the terminal part of the spinal cord, the nerve roots have to exit from the spinal canal. So they also exit, but they are a bunch. If they are affected in the disease process, that is called Cauda equina syndrome, that will give rise to a lot of pain. Sometimes bladder and bowel retention, and there is weakness in the lower limbs. So wasting of is usually asymmetric, and you have wasting. So these are the spinal cord syndromes. And now look at the nerve roots, the lower motor neuron nerve roots. I told you what is a nerve root, localization, lower motor neuron weakness, and our sensory symptoms occur in a specific pattern that is called dermatomes and myotomes. So we learn what are the dermatomes and myotomes of the upper limb, that is C5, C6, C7, and C8. So you can see these are the dermatomal distribution and how the muscles move. What are the controls of the muscle movement? For the diaphragm, the muscle movements are controlled by C3 and C4 and involving the respiration. Arm abduction, that means you have to lifting the arm laterally, is by deltoid. Elbow flexion is by biceps, that is controlled by C5. Elbow flexion also contributed by C6 biceps, and elbow, that is extension, and wrist extension is C7. C8 T1 are small muscles of the hand, finger flexion, abduction and adduction of the fingers. That is in the upper limb. The lower limb, hip flexion. You have to flex your hip by iliopsoas, that is L2. You want to extend the knee, which is quadriceps quads we call, or hip adduction, that is L3. And ankle dorsiflexion and knee extension, ankle inversion is L4. Toe extension, ankle dorsiflexion also, knee flexion, hip abduction is L5. Plantar flexion and hip extension is S1. So hip extension is by gluteus maximus muscle. Plantar flexion of the ankle. So these two are by S1. Abduction of the hip with toe extension, ankle dorsiflexion, knee flexion is L5, which is very important to understand the movements that are. So cervical radiculopathy means pain typically radiating from the neck and sensory loss in a dermatomal distribution. In a radiculopathy, you have a dermatomal type of sensory loss. You have a myotome which gets affected, so you have wasting and loss of function or weakness in the distribution of that myotome. And if there is any reflex also is there, that is disturbed. That will be absent. So three features of radiculopathy: the pain, sensory loss, and the indicator of muscle weakness. That's the important thing. So you look at the dermatomal distribution once again. The C3 is at the angle of the jaw. C5 is the shoulder. C6 is the digits on the lateral aspect. And second, third, and fourth finger middle, C7. And C8 is digit 5. T1 is a medial brachium. And T4 is nipple. And the costal margin is T6. Umbilical is T10. So key dermatomes, dermatome maps vary, but you should remember them. Can test light touch and pinprick. Pin should be tested with single pokes, not repeatedly. Use face as a control. So that's how you do the dermatomal sensory testing. So the key dermatomes which we have studied are depicted here, and you can see them on the YouTube lesson of this class. You can, as I said, a C2 is angle of jaw, C3 is angle of jaw, and you can see a shoulder is C4, and C7 is the middle finger, C8 is the little finger, C6 is a thumb, and C5 on the lateral aspect, and T1 on the medial aspect of the cutaneous distribution. The T2 is in the axilla. So these are the dermatomes of C3. You can see the costal margin is T6 and the umbilicus is a T10, and below that L1 is a groin. And you can see L1 in the groin, L2, L3, and you can see the L5 between toe and the second toe, the web space. L4 on the medial aspect of the leg. These are the dermatomal distributions. On the perineal region, you got S3, S4, and 5. On the back of the knee, you got S2. You on the lateral aspect of the foot, you got S1, S1, S2, S3, S4, 5. So all the dermatomes are shown to you, and you practice remembering these dermatomes. And the lumbosacral dermatomes are very important, which we have seen most common at L4-5 or L5-S1. Pain typically radiating from the low back and sensory loss in a dermatomal distribution. So three features of radiculopathy: sensory loss, there will be pain, radicular pain, and muscle weakness. If they are there, then you should know that it's a radiculopathy. The radicular pain has characteristic features. It is lancinating, shooting type of pain with a background lingering pain within the distribution of the dermatome. It is aggravated by all the features that increase the intracranial pressure because the roots are bathed by a CSF fluid because a sleeve of arachnoid and arachnoid pouch covers the proximal part of the roots. And whenever coughing, sneezing, Valsalva maneuver, all these maneuvers which increase intracranial pressure happen, the CSF pressure increases, presses on the roots and causes aggravation of the pain. That's the characteristic of a radicular pain. And thoracic dermatomes, we remember T4 at nipple, T10 at the umbilicus, and just above the groin is T12. So the myotomes, which we have already said, but you can we again put the slide here, and we are not going to read it again. So upper limb, just remember C5, it controls the elbow flexion. Wrist extension is C6. Elbow extension is C7. Finger flexion is C8. T1 is finger abduction. So these are the movements that are controlled by the spinal segments of C5, C6, C7, C8, T1. If there is a problem under C5, you have weakness in the elbow flexion, almost shoulder abduction. If there is a problem in the C6, there is weakness in the wrist extension, also sometimes finger extensions also. There is a problem in the C7, elbow extension is problem of the spinal cord. So these are the movements at the shoulder and elbow and rotation of the wrist and digits, abduction and adduction. So myotomes are the lower limb, hip flexion, L2, knee extension, L3, ankle dorsiflexion, L4, great toe extension, L5, ankle plantar flexion, S1. So by examining the great toe, you are testing L5 integrity. Ankle dorsiflexion, L4 segment of the spinal cord. Knee extension, L3 segment. L2 is hip flexion. So these are the important movements in the lower limb which we test. So then the deep tendon jerks, that is, if you remember, the triceps jerk is mediated mostly by C7. Biceps by C5, C6. The root values are very important to remember. And the supinator also, or brachioradialis, C5, C6. L3, 4 or L2, 3, the knee jerk. And S1 is the ankle jerk. There is no L5 reflex, mind you. So that finishes the spinal. Now we'll just go to the peripheral nerves, the characteristic distal to proximal gradient of predominantly sensory symptoms and signs that result in a classic stocking and glove pattern. So there is symmetrical involvement of sensory symptoms. Weakness is initially noted in the distal limb muscles. So then one catch point is if a distal weakness is there, peripheral neuropathy. Proximal weakness is there, more often it is due to muscle weakness or myopathy. So you can these sensory symptoms of hyperesthesia, you can see they can have decreased sensation and also absence of superficial pain and sensation. So these are the features of peripheral neuropathy. Positive features of paresthesias, that is abnormal spontaneous sensations that are coming, tingling and numbness that's happening without any stimulus. Abnormal sensation to stimulation is dysesthesia. You touch and there will be pain. Painful sensation to a non-painful stimulation called allodynia. These are all positive sensory symptoms. The negative ones are hyperesthesia or decreased sensation, anesthesia or lack of sensation. These are the sensory symptoms. The light touch, there are fibers which are carrying the action potentials from the receptors present in the skin and other organs. They are carried by small fibers or large fibers. Large fibers carry very fast action potentials, like which are involved in the equilibrium position. I mean, the posture and balance. So those are large fibers, and the light touch is affected by large fibers. Vibration is affected in the large fiber neuropathy, and sometimes small fibers are only affected. Then you have only impairment of temperature and pain. Weakness is predominant in the motor large fibers. The reflexes are also absent in the large fibers. So, if what the peripheral neuropathy means, peripheral nerves are involved in the disease process. In that case, there will be weakness, there will be sensory symptoms, there is absence of a reflex. These are the fibers. The polyneuropathy, two principal syndromes: large fiber neuropathy, small fiber neuropathy. The large fiber neuropathy is characterized by sensory symptoms and signs, reduced or absent reflexes. The small fiber neuropathy or sensory symptoms are present, but reflexes are normal. So neuromuscular junction, we have covered the spinal cord, we covered the roots, we covered the nerves. Now we are the neuromuscular junction, where acetylcholine is secreted on action potential, stimulating the nerve ending. Then you got acetylcholine that is secreted and which acts on the receptors in the post synapses and causes the muscle contraction. If there is a problem there, you have weakness, and the proximal weakness is more than distal weakness. And for myasthenia, it is episodic weakness. That means morning they are all right, by evening they become more weak. And fatigability is a characteristic feature that worse in the late in the day or after exercise. And the fast acting muscles like eye muscles are involved more often, and bulbar weakness, that means swallowing, is more commonly affected in neuromuscular junction abnormalities. Mind you, there are no sensory symptoms in this, and the problem can be presynaptic acetylcholine release, or it could be postsynaptic. Suppose if we cross the neuromuscular junction, then we enter the muscle. And there may be inflammation of the muscle, polymyositis, various muscle disorders, muscular dystrophies. And what happens is, here the weakness is not fatigable, but it is more in the proximal than the distal. Distal weakness is more common in peripheral neuropathy. No sensory complaints are here. There are, though, other than myalgias, and there is a problem in combing hair. There is a problem in getting up from chair or from the toilet seat, and they cannot climb the stairs. All these are features of muscle weakness. So that finishes spinal cord, the roots, the nostrils. So thank you very much for your attention, and we'll take up the brain and the brain stem in next class. Dr. Sonal Chitnis, are you there?
Yes, sir.
So we have briefly reviewed the spinal cord and the roots and the nerves, neuromuscular junction, and muscle.
Thank you so much, sir. So I would request next time to just touch upon a little bit on for the speech pathologist and physio and OTs, that when we have a corticobulbar
That we are going to take in the next class.
diseases. So a brief on this later. Yes, sir. It will be
No,
helpful for all of us.
no,
And from all of us, I really thank you for taking initiative, taking your time and teaching us. Thank you so much, sir.
next time we'll
Thank you
take
all.
up the brain on that. We'll talk of speech, language, and memory, and various other cortical functions,
Yes,
agnosia,
sir.
and things
PNS.
like that,
It will be
and
helpful.
awareness, attention. These are things which will localization the next class, which may happen very soon. I may
Yes.
take in a couple of days the other class, so that the whole thing is completed.
Yes, sir. It will be helpful.
And then brainstem also will take the various cranial nerves and how they are affected. So in general, what I have gone through the books which are for the SLP, these are all the things that are written. That's why I have taken.
Yes, sir. Yes, sir. They are very in-depth in neurobiology subject. I think we really had learned so much from you, which really are difficult to understand myopathies, radiculopathies,
And
and
I
then
have gone through all of your books, and there is so much of neurology than the neurologist reads. So that's okay then.
we work a lot with the Dr. Bhatnagar's concept of neuroscience of communication.
Uh,
I'm thankful so much we got to learn today, sir. Thank you, sir. We look
okay.
forward for next classes.
Anybody has any
Good night, all.
question? can ask a good night. Otherwise, I'll leave.
Okay,
Okay.
sir. Uh,
Bye.
it's 9:15. If anybody has
Hmm.
questions, we can just take 2 questions more.
Yeah. If anybody wants to ask, otherwise you can tell them that we
Yeah,
we are
they are
working on the
open.
nerve.
We can unmute yourself and you can ask questions, please.
I think nobody is interested in asking questions. They want to go off. Let them go. Okay.
I don't think so. People are all staying back for long, so.